Hello, everybody. Do you hear me?
Hello, Professor. Yes, we hear you.
Okay. I am glad to meet you in the new year. I wish you any kind of successes during the new year, no more disease, and all the best.
Thank you.
Каков летявам, къде ми е къде за кое да го летиш? Това? А ти е презентацията тук. Така. You see the picture? Do you see the lecture?
Yes.
Yes, okay. We start with some peculiarities, so to say, in the anatomy and physiology of the respiratory system in children. It is important because this anatomy determines the high incidence of respiratory diseases in childhood. Almost 85% of the disease are disease of respiratory system, and the infections of respiratory airways are still the fourth leading cause of death. When you talk about respiratory system, all of the four questions you have, you may start with this, that the anatomy determines the high incidence. You know that common belief is that the biggest surface exposed to air is our skin, because the surface of the skin is almost 2 square meters. But in fact, the lungs have surface in rest 28 square meters, and in deep inhalation they reach 93 square meters.
Professor,
Yeah,
could you change slides because we don't see, we just see the first one.
yeah, that is a problem. That is a problem. Let me see. Now, do you see now? Maybe it is not very well, but can you
No,
see?
not yet. We just see the first.
You see only the first one.
Yes.
Now,
No, not yet.
no, there is. I will need some help.
Okay. Sure.
It's what you chose from the choices that you have. You need to choose to share all the screen, not only one tab.
Yes, I have done this. I have done all this, but I don't know why it doesn't work. No, this is to stop.
Maybe if you stop sharing and do it again.
Now, do you see anything? What do you see? The first one? Does it change? No, I have to start from the beginning. I have to start from the beginning. Трябва да бива да мешаме това, защото не се движи, екрана ми не се движи. Дай да почнем от начало. Знам, аз се опитвам сега да го оправя, но не става. Самото начало, цял екран. Но аз трябва сега да отворя презентацията. Така. Do you see now the second slide?
Yes, now yes.
You see this, the problem with the percentage?
Yes.
And then
Yes.
the next one, the skin?
Yes, common belief.
Yeah, so the lungs have 93 square meters in deep inhalation and they consist of 3,000 million alveoli. The full-term infant has about 25 millions, and with growing, it will reach this 300 million. That is enough to cover tennis courts. You can imagine. The airways in the respiratory tract divide into two areas: the upper airway outside the chest cavity, oral and nasal cavities, sinuses, pharynx, larynx, proximal trachea. You know all this. Lower airways are within the chest cavity, distal trachea, airways like bronchi and bronchioles, and the last respiratory unit, air sacs, or the alveoli. The main feature of all these is the incomplete growth and development. Please remember this is very important. Uncompleted growth and development. That is another sentence to start your question. You may start with this. In childhood, in pediatrics, the main feature of respiratory system is uncompleted growth and development. The main difference in the upper respiratory tract, especially in the upper respiratory units, nose and nose cavities, the main difference is not anatomic, it is a scale difference. The face skull in small children is not is underdeveloped. The nose is very short, it is narrow, but with rich blood-lined mucose. Babies breathe only through the nose up to 2 months of age. They learn to breathe through the mouth because the nose is obstructed for any cause. And sinuses are underdeveloped. Here you have the picture of upper respiratory system. You know, a big tongue. The mouth is too small for this big tongue in pediatrics. I would like to stress on the nasal cavities. Just behind the nasal cavities at each side is the opening. This is the entrance to auditory tube, the eustachian tube, which is also very. It is not narrow. It is wide and more shorter. So infections come very easily from the nose to the middle ear, and we have very often this infection of the middle ear in children with infections of upper respiratory tract. What we see when we do the physical check of children is the oropharynx, in fact, only this small part. And here you see the cavities. You have here the sphenoidal, the frontal sinuses, and some other you will see later. Here is the oral cavity. What we see at the end of the beginning of the pharynx, this is the oropharynx. Here is the nasopharynx, and under it is the hypopharynx or larynx. We can see the tonsils after the 6 months of age, which are here. And the uvula is also very, very important. Some anomalies of the hard palate or the soft palate, the floor of the mouth, and so on. You know all these things. Now, pharynx, as I told you, consists of three parts: the nasopharynx, oropharynx, and hypopharynx. It is small. but with very well developed lymphatic network. Tonsils are growing after the 6 month of age. They become hypertrophic between the second and the fifth year, especially during the third year. And this is the time when we decide whether to operate the adenoid vegetation, which is here behind the uh, high in the nasopharynx, behind the nasal cavity. And the eustachian tube, I told you here is the entrance that connects the middle ear and nasopharynx. It is very wide and short, so infections come easily. Here you have the image of the adenoid vegetation. In Bulgaria, we say the third tonsil because usually we speak when people say tonsils, they mean these palatine tonsils that are here in the mouth, and the third one is the adenoid vegetation, which is high in the nasopharynx, but you see it here. But if it grows, if it is hypertrophic, it can close this passage of air in the upper respiratory tract. It is not easy to decide. We have some clinical symptoms of hypertrophy of the tonsil, of the adenoid vegetation. All the other two we can see easily, but this is not seen. It is hard to examine because usually for elder people they use this mirror which is put in the mouth, and they look in the mirror what is up, but children cannot stop to breathe, and the mirror is always wet, so it cannot see. There is a barbaric method for examining the third tonsil with a finger which is put in the mouth and trying to palpate whether the tonsil has prolapsed. It's a big one and has prolapsed here. But nowadays we do rentgenographic exam in a special position of the of the um, of the head, so that we can see the lumen of this conductive airway. Here you have the image of the eustachian tube, the auditory tube. You see in children it is wide and short. It connects nasal cavities with the middle ear, while in older people it looks like something else. I'm sorry, telephone is ringing. Now, the sinuses, you remember, we have several kind of sinuses, but in small children, they are air-filled later in life. They are air-filled later in life. They are covered with mucoperiosteum. This is a mucous membrane and a dense vascular connective tissue. And then they communicate with nasal cavity through very small gaps. You have here the frontal, the maxillary sinuses, ethmoidal sinuses, and sphenoid sinuses who develop later in teenage teenage. Children are born with ethmoidal sinuses. There are very several air cells, numerous, and they are very thin walled, so they can be infected early in life because they exist at birth, and they are separated from these nasal cavities with very thin bone laminae. Then the maxillary that are pyramid shape, they are the largest, have three recesses, and then they drain in the middle meatus of the nose, but the drainage orifice lies near the roof of the sinus. It is very near the roof, so it does not drain well. Infection develops more easily, so usually first of the sinus sinuitis we have are the maxillary sinuitis. They exist at birth, but they are pneumatic after the fourth or the fifth year. So, in fact, before 4 years of age, you cannot talk about sinuitis except ethmoiditis. And very often, when we talk about rhinitis in babies, we mean renal ethmoiditis because it is not possible that the nasal cavity is infected and the infection not to enter the ethmoidal cells. So, in fact, we must talk about renal ethmoiditis. The frontal sinuses are well developed and pneumatic only after the seventh and the eighth year. They reach the full size in puberty, and because they finish development just after puberty. And it is interesting to know that in 5% of population they are absent, they do not exist. Oropharynx, the middle part of the pharynx, situated behind the oral cavity. I told you some details about it. The oropharynx is part of the digestive system as well. You have here the posterior view of the oropharynx, and it is a conducting zone of the respiratory system because it filters, warms, and moistens air and conducts it into the lungs. Food and air pass through the pharynx, so there is a flip of connective tissue, a flap, beg your pardon, which is known as epiglottis, and it closes the glottis when food is swallowed to prevent the aspiration. The oropharynx is lined by non-keratinized squamous stratified epithelium. You will see downward the epithelium changes. The microflora of the oropharynx, you can remember the organism with this abbreviation HASIC. No need to remember, but you see Haemophilus is in the first place. All the other are very not common, but they are part of the normal oryngopharyngeal flora, which grows slowly, prefers a carbon dioxide enriched atmosphere, and shares an enhanced capacity to produce endocardial infection, especially in young children. This is for the microflora of oropharynx. The lymphoid tissue in the pharynx, very important. It is a tonsillar ring discovered by Valdayer, and it's called the Valdayer's ring. In fact, it is not only in the mouth, it is all over the neck. Too many lymphatic structures in a ringed arrangement. and it surrounds nasal oropharynx. Especially in the pharynx, it consists of the pharyngeal, palatine tonsils, lingual tonsil, which is under the tongue, and the third tonsil, or the adenoid, which is marked here, only marked, because you understood it is staying, the location is much more higher. The tubal tonsils are located posterior to the opening, the tubal one. They are very small. They are posterior to the opening of the eustachian tube on the lateral wall of the nasopharynx. We see only the palatine tonsils and these lingual tonsils, very small mounds of lymphatic tissue. They are located at the back of the base of the tongue, one on each side. Here you have the epiglottis, the thyroid cartilage that covers the larynx, and the narrowest place of respiratory system. This is the cricoid, the trachea, beginning of trachea at the cricoid cartilage. Here is a comparison between the larynx of adult and infant. You see the more this form, which is not cylindric, it is more triangular, and the narrowest place, the cricoid cartilage. Another difference between adult and child are, I told you about the mouth, the tongue, which is larger in children in proportion to mouth, the epiglottis, which is a floppier and U-shaped in children. In adult, it is shorter. The vocal cords, which are upward slant in children, while in the adult they are horizontal. And we talked about cricoid, narrowest part of child's airways, and trachea, which is narrow and less rigid in children. Lungs will reach them. Now, epiglottis, the epiglottis protects the larynx during swallowing, but the anatomical features in infants determine imperfect security. There is risk of aspiration, especially having in mind the supine position of babies. Inflammation is more easily to develop, and stenotic changes are more common. You see what is the shape in adults and the so-called omega shape in children. We can see larynx only by laryngoscopy. Now we have the fiber-optic possibilities, and here is how it looks through this fiber optic device. You have here the epiglottis, the vocal cords. These are the real vocal cords, and here you have the so-called false vocal cord, mucose, and then the entrance to subglottic space. Once again, posterior, here is the entrance of the esophagus, and here you have the vocal cords. This is the posterior view with the tongue in the base of the tongue. The anatomy of the trachea, you remember all these, the tracheal cartilages they are not real rings. They have in the behind of these rings is in fact membranous, So that the trachea can change the lumen in respiratory movements. It is narrow. These cardiolage rings are undeveloped. Very rich blood mucosa all over the respiratory tract. We have very rich in blood vessels mucosa, which is a predisposition to infections. We have too many blood vessels, so infections can enter easily the respiratory tract. And at the same time, we have too much mucosal glands that produce mucus. Fewer elastic fibers. You see the comparison of diameter in adult and infant, 20 millimeters against 4 millimeters in infant. And I mentioned to you that the posterior wall is membranous, so the caliber changes. The bronchial tree consists of the main bronchi, where cartilage is present again in C-shaped rings. As further branching occurs, progressively less cartilage is present, but fewer elastic fibers till 5 years of age, rich in blood mucus. The bronchi have well-developed interstitial tissues and lymphatic vessels. They are with smaller overall diameter. Right bronch is shorter, wide, and slanting. In newborn and small children, this is important, the air section is larger than the respiratory one. We have much more air conducting section than a respiratory section in the respiratory system. The angle of the main bronchi, where they divide from the trachea, you see in adults the right bronch is only 25 degrees against trachea, so there is more chances for intubation in the right, but at the same time, in cases of aspiration of foreign bodies, we usually look for it in the right bronch. It's easily to come in the right. In children under the 3 years of age, the angulation of the two main bronchi is equal on both sides. Then it changes slowly to become 25, 45. In lower airways is missing the collateral ventilation. You remember the interbronchial pathways of Martin or bronchial alveolar communications of Lambert and intraalveolar pores of Kuhn. This is missing in children, and they are important because they help to prevent atelectasis, so it is more common in children than in adults. One of the cases is here you have the image of the pores of Kuhn and canals of Lambert in the alveoli. The lungs. The airway formation and branching of airway is complete at birth with tremendous capacity for growth. Morphogenesis is done. In fact, it continues up to 1 year and a half, 18 months, but the growing is continuous, and the growth of new alveoli is completed at 8 years of age, while the length and caliber continues to increase until Final adult height is achieved around 24 years. So it is important, lungs are growing up to 24 years. It is important to know this and to instruct teenagers and young youth not to smoke, for instance. You see, it is important to prophylact their respiratory system at least to 24 years because they continue to grow. The newborn lung dimensions are small. They occupy relatively small part of the chest. They are raised strongly high, sometimes up to third rib, because of the big organs in the abdomen. They do not cover the heart, and the right lung is larger. Here you have the different lobes in different view, anterior view of the lungs, right lateral. There are some lobes you cannot see except in, for instance, right medial view or like the seventh lobe or nine. The posterior view and of the left and the right lobes. Here you have this is not so important, you know this. Trachea is divided into segmental bronchi and the subsegmental bronchi, or the non-bronchioli, non-respiratory and respiratory, and at the last you have the alveolar ducts. The epithelium is important. All the airways are lined to an epithelial membrane that gradually changes in the upper respiratory tract. It is ciliated. The cilia comes already. Ciliated pseudostratified columnar epithelium, and near the gas exchanging units we have the ciliated cuboidal epithelium. Here, just to remember the difference between squamous and stratified squamous epithelium, cuboidal, stratified cuboidal, the columnar, which may be simple and stratified, and pseudostratified with the milia, with the already. They are very they are important. And here we have some comparison between human and mouse epithelium in large bronchus and terminal bronchioles. You see different colors for different kind of epithelium. And the so-called goblet cells, there are Clara cells and all this. The most important are the ciliated cells, because they do the mucociliary clearance in the respiratory tract. These ciliated cells predominate throughout this epithelium and move the mucus toward pharynx, upward. This is interesting and you should remember it. Each cell has about 257 cilia that contract 1,000 times in a minute, and they do a mucociliary clearance 10 millimeters each minute. You see what good job is. We can't see it, not feel it, but it is done every minute. 10 millimeters of our respiratory tract is cleared. It is a very important defense factor, this mucociliary transport, because it traps particulate material and pathogens, and the mucous glands in trachea and bronchi, the goblet cells of these glands produce mucus to maintain this epithelial moisture. Here you have some details. If you want to know something more, goblet cells that secrete mucus and ciliated cells, the most important. Surfactant, very important product of our lungs. The definition for surfactant is that it is a surface active agent, consists of phospholipid, protein, and carbohydrates, but the phospholipid content is almost 85%, protein is about 8%, and the rest are carbohydrates. It is secreted by the alveolar type cells too. They are only 5% of the alveolar cells, but they produce this. The other 95%, type 1, are produced by these cells. They are type 2 is progenitor of type 1. The very important action of surfactant function is to lower the surface tension. It facilitates the lung expansion. It's connected with lung compliance, elasticity of the lung, prevents lung collapse. As alveoli radius decreases, surfactant's ability to lower the surface tension, it increases and lowers the surface tension. Surfactant prevents also pulmonary edema. In cases of surfactant deficiency, we see immediately after birth, especially in babies with low weight, it is the missing or absolute miss or not functioning surfactant causes respiratory distress syndrome of the newborn. The lung is rigid and edematous, and the alveoli collapse. Pleural membranes and pleural cavity. You know that visceral pleura covers the lung. Here is the visceral. While parietal pleura lines the ribcage and covers the upper surface of the diaphragm. And this space between the two pleura is the pleural cavity. So the visceral covers the lung and the interlobar fissures as well. So after a pneumonia, or sometimes we see on the on rentgenograms, we see the pleuritis. Sometimes the interlobar pleura are marked because the fibrin, after the inflammation, fibrin is formed, and sometimes we have no pneumonia, but we see a marked interlobe, and so we call it marked interlobe. That means there has been an inflammation there, because the visceral pleura is covering not only the lung, but it enters interlobar spaces. We talked about it. It provides mechanical support to the lung and limits the lung expansion protecting the lung, contributes to the elastic recoil of the lung and to lung deflation. Normally, we have 5 to 10 milliliters of clear fluid in the pleural space, which lubricates the opposing surfaces of the visceral and parietal pleura during the respiratory movement. The formation of this fluid is a result from the hydrostatic and osmotic pressures. And when this fluid in the pleural space starts to increase, it is, you can see it up. Sometimes we have it, all the lung cannot be seen because this fluid covers the whole, and we see it on the X-ray. Here you have a big amount of pleural fluid, pleuritis. It is regulated with this delicate balance between oncotic and hydrostatic pressures, and the movement of the chest wall, the diaphragmatic movement, enhance the absorption of excess pleural fluid, large particles and cells through performed stomas. Some words about normal pleural fluid. It is a clear ultrafiltrate of plasma with a pH between 7.6 7.64. The protein content is less than 2%, and white blood cells are fewer than 500 per cubic millimeter. The glucose content is similar to that of plasma. Lactide dehydrogenase is less than 50% of plasma, and the microelements like sodium, potassium, calcium, the concentration is similar to that of interstitial fluid. The differential formula of the white blood cells, you see 75% of cells are macrophages, which is important to defense, and only 23% are lymphocytes. There are some mesothelial cells, neutrophils, and eosinophils. Here you have this large opacity of the left side with the obliteration of the costal phrenic angle here and here, and this so-called fluid stripe. You see, I don't know if you can see, but it is marked here. Is this fluid stripe? Here is the fluid. This is the inflammation of the inflammation process in the. It is a lobar. Obviously, it is a lobar pneumonia with. You see, there is a shift to the right. Here is this is a small child. You see the heart is a little bit to the right, and the trachea, you can see it is distorted to the right because of this big inflammation process to the left. Respiratory muscles are these that contribute to inhalation and exhalation by aiding the expansion and contraction of the thoracic cavity. But the respiratory muscles in children have very high metabolic and oxygen needs, and they are very easily tired. They consume 40% of cardiac function, ejecting function, blood ejecting. 40% go for respiratory effort. Respiration is diaphragmatic, so the main respiratory muscle is the diaphragm. All the other muscles, you see, sternocleidomastoid scales, they are important, but in physiological state, they do not take participation in inhalation. The diaphragm is the most important inspiratory muscle due to immaturity and inactivity of the intercostal muscles. The accessory muscles and the abdominals are very weak as well in small babies. You see the diaphragm usually in adult is formed like a parachute, while in children it is almost flat. No pupils, this not, and sometimes it goes very high because of the big organs in the abdomen. You understand this very explanation of inhalation and exhalation. The rib cage in children has some specificity. Orientation of the rib is horizontal. I think you have seen this already in practical exercises. And they stay like this until 10 years of age, horizontal. And there is a cylindrical form of the thoracic cage. This diameter is equal to the front posterior diameter. I don't remember the word of this section. This diameter from right to left is equal to the front, so it is like a cylinder. The major function of the lungs, you remember, is to exchange oxygen and carbon dioxide between atmosphere and the blood. And of course, it is influenced by anatomy of the airways, the mechanics of respiratory muscles and ribcage, nature of alveolar capillary interface, the pulmonary circulation, tissue metabolism, and neuromuscular control of ventilation. We have to mention some important terminology in pulmonology, like lung volumes and capacities, but you know that we cannot examine this in small children. They should be at least 6 years of age so that they can do this pulmonary exercise. The main volumes you have here, it is this, you will study this more thoroughly if you want to work in pulmonology, different volumes and capacities. Some details about lung volumes in newborn babies, you see. But just to have some idea, I don't think you should remember all this. The lung compliance, once again, I mention it, this is the term that we use to describe the elastic property of the lung and the chest wall. And there are some important details in children. The lung compliance measures the distensibility of the respiratory system. The processes that can decrease the lung compliance are deficiency of surfactant, fibrotic processes in the lungs, edema of the lungs, and the result will be restrictive lung disease. The lungs of newborns, infants, and small children have high thoracic compliance. The elastic tissue, the distensibility of elastic tissues is high, but they have low pulmonary compliance because there are no elastic fibers in the airways. So that leads to closing of airways with each muscle constriction due to the weak opposition of thoracic wall. Thoracic wall is more susceptible. The elastic recoil is important. This is the tendency of any stretched object to return to its original shape, and this happens to chest wall, diaphragm, and lung during expiration, which are stretched during inspiration and recoil to their original shape. And these elastic elements behave like springs. Here you have the lung recoil springs and the chest wall recoil springs. So the lung matrix of a neonate contains only small amounts of collagen. The elastin to collagen ratio changes during the first month and years of life and affects the lung stiffness and the potential for overdistension and recoil. The lung recoil increase with age in children over 6 years of age because more elastin, more elastic fibers develop after this age. The preterm baby, they have very compliant chest walls. There is no position to collapse and low. This is the functional residual capacity, very low. The deficiency of surfactant leads to that lung volume achieved during inspiration is rapidly lost in expiration, and this needs high opening pressure and high energy expenditure with each breath. This is the importance of the elastic recoil. What are the clinical implications of this? The decreased recoil of the infant chest wall increases the possibility of lung collapse in the setting of lung disease. The excessive compliance of the infant chest wall requires the infant to perform more work than an adult chest to move a similar tidal volume. So during respiratory distress, a significant portion of the energy which is generated from diaphragmatic contraction is wasted through the distortion of the highly compliant ribcage. Diaphragms could fatigue and infants could become apneic. This is the explanation of some of the apnoic pauses in children. This extremely energy that is lost in for the respiratory cycle. The resistance, some word about the You know that we should describe the property of the lungs that resist to the airflow. Uh, a pressure is required to overcome the resistance of the respiratory system so that gas can be forced through the airways. So we talk about airway resistance, and it should exceed the viscous resistance of the lung tissue. This is the tissue resistance. But you know, these physiology, these are details about physiology of mm, respiratory system. I don't think you need this now. Maybe next year when in sixth course. So don't bother with these details. Now, you should remember only that main site of airway resistance in the adult is the upper airway, but in children younger than 5 years of age, the peripheral airway resistance is 4 times higher than adults. And this is on behalf mainly of the medium-sized bronchi. The major site of resistance are the medium-sized bronchi. 4 times higher than adults. The peripheral airway resistance. Just remember these several factors, different factors affecting air resistance. Of course, the most important is the obstruction of airflow in the airways. It is increased when the patency or diameter of the airways is reduced, and it may be caused by several causes. You see changes inside the airway, for instance, some retained secretions, or changes in the wall of the airway, like even neoplasm of the bronchial muscle structure, or some changes outside the airway that are tumors surrounding and compressing the airway. When one of these conditions occurs, the radius of the airway decreases, and of course, the resistance will increase. The respiratory diseases are mainly obstructive disease. About 90% of them are the obstructive type disease. That means it is more difficult to get the air out of the lungs. They have decreased capacities, different kinds, all these that you know in adult volumes, and usually they include emphysematic processes, chronic bronchitis, and asthma, especially in children, because you will not see emphysema and chronic bronchitis in children, of course, except in chronic pulmonopathies. I don't know whether we will have time to mention them because you have only 3 more lectures, and I have to give you the hematology lectures because the next semester mm, will be Docent Uzunova will read you lectures, and she prefers me to to give you the hematological lectures. So we have many small time for respiratory tract, but if you use this textbook of Nelson for students, it is very well written book, and you have everything there. So don't bother. But I want to give you some details that are with some practical importance. The restrictive disease, they make more difficult to get air in the lungs, only small percentage. They restrict the inspiration, and this includes severe processes like fibrosis, sarcoidosis, some muscular disease outside the respiratory system, or chest wall deformities. The predisposing factors to remember: ongoing lung and chest wall development. They continue to develop, you remember, up to 24 years of age. Immature collateral ventilation, they are prone to collapse. Lung very compliant, prone to over distension. Chest wall is remarkably compliant. Poor recoil of the infant chest wall. Very high peripheral airway resistance in children younger than 5 years of age. So we have more airway diseases, infections, and the control of respiration. The respiratory control centers, in fact, there are several small cells in the brain stem, in the pons respiratory centers and medullary respiratory centers. Just to have some impression, the respiratory control centers are in the pons. Peripheral chemoreceptors, carotid bodies located in the carotid sinus, and aortic bodies located in the aortic arc. The influence of different chemical factors on respiration. You have here all the chemical factors and the effect in peripheral and central receptors, just to have some impression. In fact, what do the lungs do? Their primary function is gas exchange, let oxygen move in and let carbon dioxide move out. So, ventilation is the movement of air between the atmosphere and the respiratory portion of the lung. Perfusion is the flow of blood through the lung, and diffusion is the transfer of gases between the air-filled space in the lung and blood. These are the main physiological functions of the lung. I won't give you all the details. You may see them if you want, but I think this is physiology and pathophysiology. Um, what you should remember is that the impairments of ventilation mean increased respiratory efforts or work, and we have the dyspnea, which is a subjective sensation not to have enough air. It may be inspiratory dyspnea or expiratory or mixed, of course. Ventilatory disorders, I mentioned it, 90% in children are obstructive type. That means narrow or blocked airway, obstructed airway. Different causes for this. And you have here the healthy one and the swelled wall of the bronch, and during a mild asthma attack, for instance. While in inflammation, we have, while in severe asthma attack, we have the chronic inflammation, allergic or eosinophilic, if you like, inflammation, and much more decreased lumen of the bronch. When we have obstruction of the upper ways, the leading symptom is difficult inspirium. first part of the respiratory cycle is with the upper part is inspirium, the first part of the respiratory cycle. In the lower parts, we have difficult expirium. It's easy to remember, but sometimes I see practicing doctors that do not know what is the difference. Here you have the restrictive ventilatory disease, in which we have decreased pulmonary volume, so they are restrictive. That's because of pleural changes or chest or lung, extrathoracic, or sometimes they are mixed diffusion, perfusion, diffusion, transport, different. The main things for children. Large occiput, thin and narrow underdeveloped mandible, floppy omega-shaped epiglottis, narrow nares, large tongue, high larynx, high location, and narrow subglottis. Some important specificity. The airway is short and narrow. You remember this difference? In normal infants, it's 4 millimeters. In adults, 8 millimeters. And trachea is 20 millimeters, if you remember. The shape of the chest and the size of occiput, the large occiput relative to the torso, the difference in trachea, the different angles of the mainstem bifurcation, the diaphragm and the thoracic cage once again. And that's all for the anatomy. Now I would like to show you the next one, which is about inborn anomalies of respiratory system. But I'm not sure. Do you see it? Do you see already?
Yes, Professor.
Yes, you see. Okay. Now, it is a very long lecture, but I would like to stress we start with malformation of the nose. You can read all this because it is the most important things are written. There is a case report, congenital anomalies of the nose. You see some awful things. Atresia, juanal atresia. You see there is no opening between the nasal cavities and the upper respiratory airways. It is closed. It may be, usually it is bone. In small percentage, it is a membranous septum between the nose and the nasopharynx. And usually it is connected with many other congenital anomalies in 50% of children. Sometimes some changes in the vomer bone under the septum of the nose. Here you have a very big vomer bone and this angle of the maxillary bone that closes the opening. You see here the opening of the nose. Some eruptions into the nasal cavities. They are rare phenomena, but with increasing the last years with increasing frequency, and usually these are teeth, rare and congenital anomalies of the nose. This is important with a big practical importance in children. The congenital nasolacrimal duct obstruction, and this is congenital anomaly, but we have it sometimes after infection of the eyes, which are often in the small age, especially in infant age, because at that age children are prone to bacterial infections, and usually staphylococcal infections can cause conjunctivitis, and sometimes these secretions, which are purulent, they can close the duct and it cannot drain into the nose. So usually in our first check of the newborn baby, we study mothers how to clean the eyes with physiological dilution, and we study them to make a light message of the eye in this direction from the outer angle to the nose, with a small push here over the duct, so it should be drained. And they tell me, I see that some secretion comes from the out of the eye after my message. So after this message, to clean the lacrimal, this sac here, this uh, canaliculus, we have to drain it, and then we can clear with saline dilution, or if we need some antibiotic drops to treat. So from practical view, you should know this to do this message first, to do this light message of the eye in this direction. So if the nasolacrimal, in fact the lacrimal duct is obstructed, the only treatment is surgery, and usually it is done later at 6 7 months, because it needs anesthesia, and they are doing with this, I don't know what is the name in English, bougie. They with different kinds of special, they puncture the caniculus, changing slowly, increasing the dimension of this needle, so that the ductus is opened. But this needs more time and anesthesia. So we try to prevent this to happen, and this is important practically. The blocked tear ducts, you have here some details. In the pharynx, we may have some mucosal cysts, different kinds of cysts. Here you have cyst in the vallecula. We have some congenital middle line nasal masses. They can be dermoid cysts or gliomas or encephalocele. They are not very common, but all of them have potential for intercranial connections. and they may present as a mass on the nasal dorsum or intranasal mass. So we must be very careful, and the only treatment is surgical excision. Here you have a nasal glioma, another awful glioma. The thyroid, an ectopic place of thyroid gland under the tongue, lingual thyroid. Abnormal mass of ectopic thyroid in the base of the tongue, some embryological aberrancy in the development of the gland. And it is interesting that it may function normally, no matter that it is in another location. You have a differential diagnosis of different masses in nose and nasopharynx. You see polyps and hemangiomas, some carcinomas, cysts, and so on and so on. Here is this baby with polyrynia. You see, it was born with two noses and something like a third eye. And with after long preparation and multidisciplinary equipe, it was operated, and you see quite a good-looking child. Here are the different phases of or studies study state of operation. Different malformation of the oral cavity, like they in fact they are not so important for but some of them they are not so important for respiratory tract. They are important for digestive tract, but some of them, you see, like encephaloceles or granules, hamartoma, and some other big masses, they can block the airway. Different malformation. You will here is a baby with a big tongue and ankyloglossia as well, because the frenulum is very short. Here you have this abnormal lingual frenulum or ankyloglossia, and it can it is more important for the feeding of the infant, but sometimes it may do harm to respiratory tract. Here you have a ranula prolapsed in the mouth, and this is the explanation, the details about ranulas, not so often. Hamartoma, these are, all these formations that resemble neoplasma in the tissue, but in fact they are benign formations. For instance, in the breast, here you have it in the beginning of the trachea, hamartoma. Dermoid cysts that consist of, they have skin and hair follicles and sweat glands and some many other components you can find in a dermoid kyst, even teeth and eyes, cartilage, thyroid tissue, and all this. I had a friend who was operated for a dermoid cyst over the left brow, and the surgeon was joking that he has operated her twin brother from this. It consisted of so many structures that it was almost her twin brother. Anomalies of the larynx. They are relatively rare, but are life-threatening, with symptoms of airway obstruction, difficulty in feeding, and of course abnormalities of phonation, because the larynx is the place with the vocal cords, and the process of the obstructive symptoms vary from mild stridor to severe obstruction, with episodes of apnea and cyanosis, suprasternal subcostal retractions, dyspnea, tachypnea, and chronic obstruction cause failure to thrive in the small babies. Here you have the picture of a normal larynx and the absolutely closed. Maybe this is a paresis, inborn paresis of the vocal cords. In larynx obstruction, we use terminology. The noise is called stridor. It comes from the verb stridulus, that means creaking or grating voice. This is a vibrating coarse sound with different frequency. When it is inspiratory, that means the process is in the larynx. In expiratory stridor, we think about process in trachea, and we may have biphasic, of course, larynx and trachea. The morphological substrate is obstruction of upper respiratory airways, uh, where the airflow is turbulent. So, stridor is noisy breathing in the upper respiratory tract, and wheezing is the noises in lower respiratory tract. When the noises are louder when sleeping, that means they're in upper respiratory tract, nose and pharynx. If they're louder during awake state, that means larynx, trachea, and bronchi. The congenital anomalies of the larynx, the most important that you should know are the laryngomalacia, the vocal cord polarity, they are the most common, and subglottic stenosis. There are too many of them, but these are the most important. Laryngomalacia. This is the most frequent cause of stridor in infants. It is the stridor is inspiratory, low pitched, and it results from collapse of the supraglottic structures inward during inspiration, because the larynx is undeveloped. Laryngomalacia. Here is the normal larynx, and here you have the omega-shaped larynx, omega-shaped in laryngomalacia. Usually, in the first 2 weeks of life, they increase in severity to 6 months, although the gradual improvement can begin at any time, but usually after the 6 months, when the larynx starts to grow more obviously, and all these symptoms are exacerbated by any exertion, crying or agitation during feeding, the supine position as well, and the viral infections of the upper airway. In some children, because of decreased laryngeal sensation and poor suck, swallow, breath coordination, feeding difficulties and dysphagia develop. In all the small children, the suck and swallow and breath coordination is not enough good, not well developed, not well controlled. So we have to, so they usually only drink, they eat only fluids up to 6 months of age. So some of them have feeding difficulties and dysphagia. Diagnosis by flexible laryngoscopy, and if we have dysphagia, we should do contrast röntgenogram of the esophagus, but you see quite a big percent of these babies with laryngomalacia have some other anomalies, so a bronchoscopy is preferred to see all the respiratory tract. Most of the symptoms resolve spontaneously, but apparent life-threatening events or quick development of cor pulmonale, cyanosis, a failure to thrive, they need surgical intervention, and usually a supraglottoplasty is done with tracheotomy. You see here this is the tracheostomic tube and the knife, so to say, of the surgeon. The subglottic stenosis may be congenital or acquired, and the nature may be membranous or cartilaginous or mixed with combination of glottic or epitracheal stenosis. And you have here some details about normal diameter of full-term infants, which is 4 millimeters, we mention it, and premature infants 3.5 millimeters. But you should remember that circumferential edema of 1 millimeter reduces the cross-sectional area with 60%. So it is very important to treat this stenotic event or disease, because only 1 millimeter edema lowers the work, the passage of air with 60%. There is a grading system of the different kinds of stenosis. These are some details that you don't need. The subglottic stenosis is second cause of stridor in infants, mainly inspiratory or biphasic, may be persistent, may be recidivant. First symptoms appear like many other inborn anomalies after during the first infection of the baby. You do not suspect anything until the first infection of the infant. A sudden episode of stridor during night or early in the morning, then comes the edema of the walls and hypersecretion in this stenotic place. Vocal cord paralysis, the third most common anomaly, but it is often associated with myelomeningocele, the malformation of Arnold-Chiari, and hydrocephalus. So it is not only paralysis of the vocal cord. It may be unilateral, aspiration, coughing, choking. They cry with a coarse cry, very weak but coarse, and maybe no stridor. When it is bilateral, there is inspiratory stridor. You see here the unilateral paralysis, bilateral paralysis, and this is the malformation of Arnold-Chiari. Chiari was the first one to describe it, and Arnold. This is the downward displacement of cerebellum, very serious, and they have, as you can expect, they have ataxia, and the external hydrocephalus, which is, you see here, the stomach, and this space is filled with liquor and change in the skull. This is the combination with, and it is interesting that we should do the diagnosis by awake laryngoscopy because it is a dynamic lesion. It cannot be seen in sleep, during sleep, or under anesthesia. But we need as well a neurologist and cardiologist consultation and endoscopy of trachea and bronchi. It is interesting that they usually resolve spontaneously within 12 months, 1 year. Sometimes they need 2, 3 years. But bilateral paralysis, of course, may require temporary tracheotomy. Subglottic hemangioma, practically we should suspect, many children have some skin hemangiomas, but when we have on the skin, we always suspect hemangioma with some other location, especially in parenchyma organs. And here you have subglottic hemangiomas, which are usually asymptomatic till the 6 months of age, and 50% have associated cutaneous hemangioma. And when they present with stridor, which increases on agitation, and the stridor on crying is due to filling of the vena of these children. They are not very informative, these pictures here, but I couldn't find anything more. The treatment of these hemangiomas, here you have cutaneous hemangioma, quite big one in the face, is usually corticosteroids, and they are directly applied into the lesions. Sometimes some schools, surgery schools, try interferon treatment. Of course, in stenotic hemangioma of the trachea, we need tracheostomy and laser excision of this hemangioma, endoscopic. Atresia of the larynx. It is a rare anomaly, but causes obstruction of the upper fatal airway, and it is known as house congenital high airway obstruction syndrome. Distal to the atresia or stenosis of the lung, the lungs distant of this atresia or stenosis, the lungs are enlarged and capable of producing echoes, echogenic. The diaphragm is flattened or inverted, and there may be fatal ascites and heat drops because of the accumulation of serous fluid. And usually prenatal ultrasonography permits the diagnosis. Here you have laryngeal atresia endoscopic view. Laryngocele and saccular cysts. You have here the schema, abnormal dilation of the sacculae that communicates with the lumen of the larynx. They are usually filled with air or mucus. Saccular cysts are cystic dilation of the sacculae that does not communicate with the laryngeal lumen. They are thought to develop due to non-patent saccular orifice, and the cysts is distinctly submucosal and are covered with normal mucous laryngocele. Here you may have ventricular bands, you may have internal laryngocele, different kinds of anomalies. Here you have a cell, you see, which is making this edematous view of the and this is the picture after the treatment. Inborn anomalies of the tracheobronchial tree are rare. The first presentations are usually in the period of the newborn, and they have three cardinal symptoms: the respiratory distress syndrome, stridor or wheezing, and then continue with recurrent infections of the upper ways. The tracheobronchial anomalies may be tracheal agenesis, tracheomalacia, tracheal stenosis, the tracheoesophageal fistula, and bronchial atresia. Agenesis and atresia are rare anomalies, and they are incompatible with life, usually associated with other congenital anomalies, particularly laryngeal and tracheoesophageal fistula. Diagnosis, of course, through bronchoscopy. Tracheal agenesis. Here you have, they are rare, usually when there is the situation of maternal polyhydramnion, and usually there are three types. The absent upper trachea is absent, the lower trachea is connected with the esophagus. Second type, the common bronchus connecting the right and left main bronchi to the esophagus with absent trachea, no trachea, the main bronchi directly, and or the two main bronchi rise independently from the esophagus, very severe anomalies. Here you have some different cases of atresia, fistula between trachea and esophagus, and atresia plus fistula, many different types. The tracheoesophageal fistula is in 87% atresia of the esophagus and distal tracheoesophageal fistula. Here you can see here different types, many. But you see, it is quite common. It is not rare. 1 to 3,500 births. Males predominate, very common in prematurity. In 50% we have associated anomalies, and most of them are cardiac anomalies. The clinical features are the excessive salivation, constant drooling of saliva from the mouth, and violent response during feeding. The 3C: coughing, choking, cyanosis. These are the main symptoms. Fluid returns through the mouth and nostrils, frothy salivation, abdominal distensions in some of the types, and of course aspiration pneumonia. Here are the three same. We may do prenatal investigation because the ultrasound reveals polyhydramniones, absence of fluid-filled stomach, small abdomen, and distended esophageal pooch. And of course, the fetal MRI will be confirmatory. After birth, the X-rays usually are done with radio-opaque catheter in the esophagus to check for obstruction, and the bronchoscopy, of course, shows this fistula between trachea and esophagus, and there is inability, of course, to pass nasogastric tube due to resistance. We had the last suspicion for tracheobronchial esophageal fistula was in our neonatal ward maybe 2 years ago, 3 years ago, before the pandemic started. A small baby, a newborn baby, normally born, well developed. On the first feeding, it started to vomit. So, with suspicion, no examination, no investigation was done. It was transferred immediately into Pirogov Hospital, where is the infant surgery for inborn anomalies, especially, and it is a very good clinic with big experience, because all over the country, all the serious conditions they are operated there. But fortunately, it was only a stenosis of the esophagus, which was overcome very easily. Slowly, it was pushed slowly every day with increasing diameter, and the child was dismissed on the 15th day after birth. So it was not this awful tracheoesophageal fistula. Here you have different spectrum of phenotypes of the cartilage, the trachea changes inborn, and some details about evolution. I am going to stop this lecture. It continues downwards. You will see many different, but I have tried to read most of the important details about all these inborn anomalies. So you will have anomalies of the lung, the last one. But I think you will find all this written in the textbook. But here you have more details and photos, so that it is easily to remember. I will send you the today's lecture. So I wish you good rest, and next Tuesday we continue with hematology. Okay?
Okay, Professor, thank you very much.
Good evening.
Good evening.